So what is hypertension? And in a sense, so Rod Jackson would say there's no such thing as hypertension because it's a continuous curve. So irrespective of your age, a lower blood pressure is better than a high blood pressure. This is ischemic heart disease mortality. So this is cardiovascular risk. And this is a logarithmic scale. That's 256 times that. So that's massive, you know, that's going through the sky. And in a sense, this is hypertension, but there's nowhere you can put that. You can't say, that's hypertension, or that's hypertension. And in fact, as he and I sort of agree, hypertension is sort of a line that comes across here in a funny sort of way. But the key thing to think about is so what's this? A 10 millimeter drop up here compared to a 10 millimeter drop down here, you're getting very little benefit for a 10 millimeter drop in blood pressure here, assuming that treatment translates. So this is observational data, treatment data translates into it. A 10 millimeter drop here, and you're getting, you know, 30 or 40 times what you're getting down here. So the game I want to play with you is, you've got 5 years supply of antihypertensives. You know, the global warming has occurred, Korea has set off the bomb, there's no more antihypertensives. You've only got 5 years supply left. Who would you give it to? These people? These people? Or these people? I can tell you the numbers needed to treat to get a benefit. The numbers needed to treat to get a benefit up here are about 6, up to 100 here, and up to 1,000 here, over 5 years. We're just looking at 5 years. Okay. Now I won't get you to vote, but most of you would probably go for somewhere in the middle there. And if you're young, you probably think, well, this is the group you'd want to treat if you only had 5 years. Now, it's a game. But of course, nothing's going to happen to this group. They'll still all be alive, and well, virtually all of them. And you know, you can only prevent a third of events, remember, with any intervention. You know, I tell the medical students that doctors and medical students are in love with their drugs and devices, and that most drugs don't work for most people, and they all laughed. So I said, okay, tell me how many drugs have a numbers needed to treat of 1. Dead silence. Because only drugs with the numbers needed to treat of 1 work for everybody. And there aren't very many, perhaps isotretinoin for acne, penicillin for meningococcal disease. We actually don't have very many things. You know, our pharmacopoeia and you know, is not as great as we live in an era of wonderful drugs, but actually most people don't benefit from most drugs. Yeah, so that's that. So I'm just going to talk about lowering in the elderly. So there was the SPRINT trial a couple of years ago where they looked at lowering from 140 to 120. And then last year they published the older age group. And of course, there was no surprise, there was more benefit in the older age group than the younger age group, as I had shown you, totally predictable. Totally predictable. JNC8 actually suggested a goal of below 150 rather than go below 140 for people over the age of 60. And this to me is sort of going back to the dark ages when Rafe and I trained, that, you know, hypertension was 100 plus your age. And so some of you who are my vintage will remember that. That was hypertension. And that actually you couldn't treat systolic hypertension. That's what I was taught at medical school. And now we only treat systolic hypertension. So that's something it's one of those things that have flipped 180 degrees. Okay, so this was the trial. There were 2,006, so it's a pretty big trial. The whole trial was 9,000 people. It was stopped after 3.2 years because the benefit was statistically significant, so the data monitoring. These people had a high CVD risk, 24% over 10 years, so that translates to about our 15%. The problem, of course, is once you get up here, is everybody's like that, even if you haven't had an event. By the time you're 80, your CVD risk is getting up pretty high, unless you're extremely low risk. So a lot of people, as they get older. Blood pressure at baseline was 142/72, And in the intervention group, it went down, it was an open label trial, and it went down to 123 in the intervention group, 135 in the control, in the non-intensive. So that's the non-intensive group. So this was the composite outcome. There was 10.9, so they added them all up because it's about the only way you can do these trials these days. If you look for specific components, like heart disease, stroke, you'd need like 1 million people. But, so they add them all together, 10.9% in the intensive group, 15%. Numbers needed to treat of 22. So that's against an active comparison. So both groups were getting treatment. Deaths, interesting, the deaths were statistically significant. They weren't going for statistical significance for death. They were going for statistical significance. But by the way, they found that deaths were lower, which is nice. But, and you had to treat 38 people to do. So how best to explain to the patient? So, and we're going to have cases. So how do you inform people? I'm going to show you the website from the Therapeutics Collaboration in Canada, where they actually have smiley faces going up, and you put in the patient's risk, and you click low intent. Does anybody use this? It was one of my gems. You use it. Fantastic. I think it's the only way you can inform somebody. Patient says to me, well, should I take a statin? He's 50 years old, he's Maori, lipids are, you know, he's about 15% risk. And I'm thinking, I can't make that decision for you. And I flip open the website and show him, and he has a 4% absolute benefit over the next 10 years. And he says, is that all? You know, you want me to take a pill for the rest of my life? For 4%? In the next 10 years, admittedly, in 10 years' time, his risk will be higher. And as he gets older, he may want to change that. Now, which is interesting, because me, 4%, as a doctor, I'd be happy to take it. I'm happy, I take a statin. I'm happy to take a statin for that sort of benefit. But I can't, I'm not in his value judgment world. You know, he's not on any medication at the moment. He's not that excited about taking a pill for the rest of his life. So here's the smiley faces. So this is what happens over 3 years to somebody with the composite events. Now over 10 years, that's 12. That's 12% of people. Now the program actually won't deal with blood pressures below 140 at the moment, and I just made this up. But I think, and you can say, well, so if you take this pill, most people won't benefit. Most people don't benefit from most drugs. And some people will still have events. I can't promise you won't have an event. Of course, we never know. If they have an event, we still don't know if we prevented an event. They've just had an event. And so this is over 3 years. So you have to multiply this out by 4 to get 10 years. And I've got one of the cases I've got is a patient of mine who, even when I showed her this, she was 82, she said, well, what would you do? And I said, well, blood pressure is about 155, 160. I said, I'd take the medication, quite frankly. Because I'm thinking, I don't want this lady, if this lady has a stroke in 3 years' time, I'm going to feel bad. I haven't done everything I could. She's a very fit lady. She goes on cruises twice a year. And it seems to me there's that issue of informed consent. Okay, what might you regret if something happens? Like if she's 85 and has a stroke, I would have not felt great about that. But she asked me point blank what I would do. This didn't help her. Most patients, I find, this helps enormously. And almost invariably, they don't want to take the medication, which has been a real eye-opener to me. You know, because as I say, I'm happy to take the medication. 4%'s way too high for me. But, you know, and I've got some patients that 1% would be, you know, way too high. So that's when you look at the younger people. So this is the older people. So the older people get more bang for their buck, over 75. This is the whole group over 3 years. Again, they stopped the trial early. So that the downside, of course, is the medications. You need to take an extra medication. And does anybody here use chlorthalidone? I have a little group that's trying to get chlorthalidone. We've published an article in the Journal of Primary Healthcare about a month ago, just showing that compared to, there's more evidence around that as an antihypertensive. It's better than ACE inhibitors. It's at least as good, if not better, than ACE inhibitors or calcium channel blockers. And it is funded. It does have the downside of having more electrolyte disturbance. That's the downside of using it. But and they used it in this trial because they didn't want the Americans using hydrochlorothiazide because they don't give the right doses in America. They're all giving 25, 30 milligrams, 50 milligrams. You probably need to give 100. The only trials that have showed a benefit. Bendrofluozide, our lovely favourite drug used by 90% of the country. In fact, there's no evidence that it alone reduces cardiac. There may be an absence of evidence, but it doesn't lower. It has to be with something else. The old moduretic type combinations, or Navidrex K, that some of you will remember. So in combination it's being shown to be effective, but alone it's not. So we may well be giving the wrong, and if you only had one drug and you're on a desert island, I'd take chlorthalidone. Okay, so here's the harms. Hypotension 2.4 to 1.4%. Syncope, more in the intervention group. Electrolyte disturbance. But serious falls were lower in the intervention group. So what's happening there? I suspect you're preventing TIAs, strokes and heart attacks because you've lowered their blood pressure. And these people aren't having, there's an absence of serious events, because I would suggest to you the serious falls are probably due to, you know, arrhythmias, TIAs and that sort of stuff. Acute kidney injury was slightly greater, and that's just an increase in your EGFR, so your creatinine during the study. Doesn't actually mean, in fact, the most recent thing, I've just got an abstract this week to say actually there was no difference in terms of kidney harm.
So the striking thing there, Bruce, is actually the risk of adverse events is remarkably low, really, in absolute terms for increasing the blood pressure medication. I think when you're talking to patients, often there's a perception that the risks or downsides of the medication are somehow higher than that.
Yep.
And there's a big difference. You know, these things are kind of temporary as opposed to a stroke, which is permanent. So I just find the discussion you have with a patient about risk and benefit quite difficult. If you just put a 4% risk and they say, oh, that's too low, and then the other thing, oh, that's too high, and I think in the end, I mean, we do have to guide people. But you know, if you're 50 and you have a stroke and you can't talk and you can't walk, that has a devastating effect on your life. And you know, if you can take a medication, that's just taking a medication. I mean, it's just I think it's how you frame it becomes so important. And I mean, it's very interesting. I mean, everybody has a different perspective, but I just feel that how we frame these decisions is so important.
The language we use convinces people most of the time, I think. So these people were, and I'm going to show you the frailty index, which I think is fascinating. These people were all mobile outpatients. They weren't symptomatic. Because if you listen to Chris Cameron's deprescribing thing, she's talking about the inpatient elderly. They're not a group you want to start medicating. But I'm trying to make the case for the walking, and I'll show you some of the frailty stuff, which is fascinating. As Rafe says, in fact, when you look at the side effect thing, and you've all seen this in patients, they all complain of side effects as soon as they're on things, but actually over a period of time, the side effects pretty well disappear. I mean, there's some classic ones like swollen ankles with calcium channel blockers, cough with ACE. In fact, I've actually started using ARBs as my first line treatment because losartan's fully funded. I thought, why do I put somebody at risk of coughing? You know, we're also, you do ACE inhibitors first and then you go to ARBs, but that was a funding decision. And now losartan's funded. Candesartan isn't, I don't think, but losartan is. Why inflict a cough on a patient? Okay, what about the frail elderly? Okay. So there's a frailty index. Now the problem is converting this frailty index into what does the patient look like in front of you? But these are people you see in your office every day. They're not people in bed, they're not in institutions, they're mobile. Actually, the drugs were only effective for the more frail, which is fascinating. So when you think about it, the frail elderly person has a frail cardiovascular system, which is going to pop under high blood pressure. When you think about it, you have to sort of get your head around what's going on with this.
I mean, it's absolutely fascinating, isn't it? The frail people have 3 times the risk of the non-frail.
They've got the big risk, and they're getting the big benefits. Not significant. There were hardly anybody in the fit category. There were quite. I haven't put the numbers in here but NNT of 28, NNT of 20. This is what you'd expect. As risk goes up, numbers needed to treat goes down. Not massive numbers needed to treat. But actually, NNT of 20 is probably better than most of the things you're doing most days, I regret to say, guys. So, okay. So I think we need to inform patients, and I'm going to use the Canadian Therapeutics Collaboration thing. It was one of my gems that said this is a great way. It's based on Framingham, but of course the problem we're going to have with the New Zealand equation is everyone's treated. Framingham overestimates now. Framingham way overestimates CVD risk. But the New Zealand equation, when it comes out, is full of treated people. So how are we going to interpret that? So it's going to be, I don't know how that's going to happen, how the Heart Foundation are going to deal with that. Vancouver, and things like hip fracture, if you've got a very fragile, slim, elderly woman perhaps, you're going to want to think about them falling. And then think about chlorthalidone. So we don't have any combinations here, which is a pity, but it is the single most effective antihypertensive. And in America, there's lots of editorials about it, suggesting that should be the one they use, because they tend to use hydrochlorothiazide there. I say this to the medical student, there's more evidence around this than just about any drug we've got, except aspirin, although aspirin's a problem in primary prevention, which we'll talk about later. And they say, well, why isn't it used? Well, the trouble is the people who use that are either dead or retired. And all the marketing has occurred since then, And if you think you're not subject to marketing, of course, there's not much marketing these days. Back when I graduated, the top prescribed drugs were the ones that had the most marketing beside them. So we health professionals, we're all suckers for marketing, Yep. Okay, so this is a Yanomamo Indian. Anybody know much about these guys? They're in the back blocks of Venezuela. Their average blood pressure is 95 on 60. Their systolic is below my untreated diastolic. So, but what's neat about these guys is that they, what my interest in these people is they consume virtually no sodium. They eat 1 millimole a day. You in this room, unless you consciously have a low sodium diet, will be eating 150 to 300 or 400 millimoles a day. They're very active. They're quite small, so they're the size of a teenager. They're very fit. They don't drink any alcohol. They have quite a bit of stress. They fight a lot. And the original anthropologists thought they fought over food, but the subsequent ones realized they fought over women. So they like having multiple wives. So, but they don't, as they age, they don't, like everyone in this room, CVD risk is higher than it was when they were 20. These guys, as they grow older, their CVD risk doesn't go up. Okay, so I just wanted to show you some quick things. So this is what happens with cardiovascular disease. Basically, if you're a Japanese person and you move to Hawaii, to California, and then have kids in California, eventually these people start looking like the locals. So that tells you there's an ecological thing, that there's nothing special about Japanese genes because they look like Californians when they have grandchildren in California. This is the what Rod Jackson based the CVD risk tables on. So if you add them all together, your risk goes up. Age is the worst one. Actually, smoking smoking actually doubles your risk. Nothing else doubles it. Even age doesn't. Well, I guess age maybe doubles your risk if you go from 30 to 70. But this is what he converted into that, which will all be etched in your brain. But this still doesn't tell you how much treatment gives the benefit. Now, this is just CVD explained. Interestingly, we all ignore the psychosocial stuff. Probably overestimates cholesterol. This is probably more for cardiovascular disease, physical inactivity, alcohol. But if we look at stroke, then hypertension becomes a much bigger one. Smoking. These things are relatively small down here. Blood pressure. It's amazing we ever make anything of blood pressure because, you get patients and it's all over the place. Time of day, time of year. So this is time of century. So this is blood pressure. This is at night time. It starts to drop at night time and it comes back up during the day. So that's a 24-hour cycle of blood pressure. Winter, blood pressures, wonder why your patients are more difficult to control in winter? I had one lady, I used to have to medicate her in the winter and stop it in the summer because she'd get out in the garden and keel over all the time. And then in winter, blood pressure would go back up again. So literally she had her winter pills and her summer pills. In the early 20th century, people used to present in cardiac failure and renal failure. From about the 1970s, GPs started screening blood pressure. And I don't know, how often do you see malignant hypertension?
Not very often.
No.
Not very often.
I mean, you're in a position to see it, aren't you? But I mean, has anyone seen a malignant hypertension?
I mean, we see it in people who never see the doctor and then present with heart failure, but it's not common.
No, I haven't seen one for 30 years, I don't think. So this is interesting. Blood pressure has been falling. Blood pressure is dropping in New Zealand. And this isn't due to treatment. This is in college, or this is in young people. There's the Barker hypothesis that people are getting better prenatal care, so some people believe that. Rod Jackson thinks it's dietary fat. He thinks we're eating lots more olive oils and things like that, probably too much, so it's making us fat, but it's lowering our blood pressure, so it's good news. So that's what's happening with blood pressure. So it's coming down. And this is in groups of people who are too young to be on treatment. So this is an untreated population. So it's quite interesting what's happening there. Now this will come into the issue of whether we give aspirin or not. And this is from Anthony Rogers and Vanessa Selak. There was an article in the Listener recently, Vanessa was in that, about whether we should all be taking aspirin. Okay, so this is secondary prevention. So this is easy. Okay. You've got a 25% 5-year risk of having something happen to you. You take a statin, you drop that by 25%. You add blood pressure medication, you drop it down down another 25%. You add aspirin, you drop it by 20%. So between no aspirin and aspirin, there's a 3.1% harm there. Over here, there is 0.6% harm by adding an aspirin. So aspirin is more beneficial than harmful for secondary prevention, so people who've had heart attacks. Not so in primary prevention. Okay, so we're starting at 15%, so this is men aged 60 to 69 years, dropping down to 11%, dropping down to 8.4%. If we add aspirin, we get a 1% gain for a 0.6% harm. Not so great, eh? And if you look at 80 to 89-year-old men, and we don't know this for sure, the precision around risk of aspirin in older people is not great. And so you've got a 1% benefit there and a 2.2% harm there. So I have to say I don't give aspirin for primary prevention anymore if I've lowered their risk this way. If I've given them a statin and a blood pressure pill, I really don't want it. And I actually have stopped aspirin on 2 patients. One had a GI bleed and one had a hemorrhage into their bladder. I mean, I guess you can survive those. It's the cerebral hemorrhage that worries me. So there's a lot of debate. And of course, if you start the aspirin in the 60-year-old, they're probably going to stay on it until they're 90. And, you know, it's very hard for us to stop medication. Okay, so here's the New Zealand Guide in a nutshell. And I have a copy of the New Zealand Guide, which I'll pass around. This has been changed as we sit. We have the electronic version if you want. Even people seen this? It's a really fantastic little book. I have to say it's one of the few books I flick through quite often. But that's probably getting out of date now. Although actually I think the statin, aspirin, hypertension stuff's the same. It'll be different for all the other things. So basically, and this is going to change. So it's a 15% 5-year risk, which is pretty high. 1 in 6 people have an event in 5 years. And of course, none of us do that. We've all been treating below that threshold. Or a blood pressure of 170 over 100. And then in terms of first line, these are the first lines. As I say, I jump the ACE and go straight to the, I tend to use losartan with hydrochlorothiazide as a half tablet as a starting dose. Because I have to say about 20% of my patients cough on ACEs. I don't know, would that? Other people find that, you know, it's a bit painful. It was very painful in the old days where you had to make them cough and then and get on to something else. Calcium channel blockers, I find problematic because of the, these are fine. The calcium channel blockers, I get sick of the swollen ankles and then having to sort of backpedal on that. Then the fourth line is tricky in New Zealand. It'd be interesting to get Rafe's view on that. Spironolactone or beta blockers. I have to say spironolactone is the most difficult drug I ever have to prescribe. My patients don't like it and it messes up their potassium, and I'm on this treadmill of, you know, watching their potassium and all this sort of stuff. The issue about targets is up for grabs at the moment. I think a lot of people would agree below 140, not below 140 if they're diabetic, but for everybody else it's a bit up in the air. And of course the problem with lipids and blood pressure is everybody would benefit. I mean, irrespective of your blood pressure in this room, if we all took antihypertensives, we would all have a lower CVD risk. And some of you would be getting sort of like a numbers needed to treat of 10,000, and some of you would have a numbers needed to treat of 20, 30, 40. So this just shows you, even with a blood pressure of that, you still get a benefit. But of course the big benefits are up here, the big numbers are up here. And it's the same for statins. Everyone benefits from a statin. So how, in the context of that, how do you inform patients rather than saying, well, you should be on a statin, which I don't think is acceptable in this day and age unless a patient asks you directly. Okay, this is my guide dog puppy. Now when I saw that photograph, I wondered, my first question was, how do you keep the dog still? He doesn't have hypertension, by the way. This is completely irrelevant. How do you keep the dog still? Does anybody know? And he's a Labrador, so food won't work. They spin them around. That's a vertiginous guide dog. That's why he's looking a little perplexed. I think it's worth it for the cute photograph. Some people think that's cruelty to dogs. But anyway, a bit of a sad story. So he made the grade and he went to Christchurch and he got spooked by the earthquakes and started peeing everywhere. So they brought him back and we had another 6 weeks of him. And they thought he was just too anxious. So he's been medically retired and he lives out in Beachlands, and I have visiting rights, so I get to see him at Christmas time.